Well, thank you, Amber, for inviting us to conduct this important panel at the end of the day when everyone's exhausted and wants to just go and eat tacos and have margaritas. So we'll try to be succinct and to the point and have a really productive discussion. My name is Yael Weiss. I'm the CEO of a company by the name of Mazi Therapeutics, and we're solely focused on developing therapies and genetic therapies for neurodevelopmental disorders. So we spend a lot of our time thinking about endpoints, especially in disorders that have not been in the clinic before and have never had specific endpoints developed for them or biomarkers. So this discussion is very relevant, and I'd love to hear from the other panelists as well, hear their background.
Hi, everybody. My name is Andrea Mealy, and I'm a pediatric neuropsychologist at Children's Hospital Colorado. I've been there for 8 years, and I've worked in rare disease for about 3 years. We have a neurogenetic multidisciplinary clinic at Children's Colorado that I'm the neuropsychologist for. And so I've just been really fortunate to work not only with kids with SLC6A1 related neurodevelopmental disorder, but other rare kind of DEEs as well. And I'm just trying to think about the tools that I have in my toolbox so to to provide your child with the ability to show me what they can do. And that's what I want. And then I hope it's good enough for the FDA in a clinical trial too.
Hello, I'm Jeanne Paz, and I'm a basic scientist. Scientist. I was very moved by everything I've heard today, and I do think that the endpoints are very important, and I cannot tell you how much time we are thinking about whether the endpoints we have for mice are meaningful or not. So I particularly enjoyed today hearing from the families about what the main problems are for them. And I heard seizures, migraines, even from certain families. That was the first time I heard about migraines, and behavioral issues. And so I think that what's really important, is to understand if, for example, the delta rhythms, right? Like Zach referred to those as seizures. Many people in the epilepsy field would tell you these are not seizures, but for people like me, they are seizures. And so if they are, causing in certain brain circuits, if they're causing some problems that are related to behavioral issues, right, then they might be causative, right? So in that case, it's really important to have that as a biomarker, right? So it's extremely important to have the EEG and all the other endpoints measured from the same patients. And what do we say then in the case, if a medication works for those seizures but does not work for behavior, what does that tell us? I guess that's a question for the audience from me. But as a mouse researcher, I think that what I want to do when I go back home with my postdoc, Yulia, I think that we need to focus more on machine learning approaches to understand behavior, because right now we are measuring the behavior that's easy for us to measure. We put the mouse on the rod. We measure the things that we know how to measure. But I think that, as Yulia described today, there are lots of interesting new approaches, right? With the machine learning and the AI that can allow us to measure things that we weren't looking for, like specific patterns. So then it's a different question, like whether those are relevant to the human behavioral deficits, right? And if they are or are not associated with what I would call seizures, absence seizures. But yeah, so I guess what I'm trying to say is that this meeting has been extremely encouraging to me, because I think that when I go to my lab, I have some new ideas on what to test, and we are definitely going to include migraine-related pain behaviors and more unbiased approaches to look at the behaviors in mice in which we are already measuring the EEG. And as Yulia said, and others have said, we do see this slow EEG slowing that we recently published on together. Sorry, it was long, but hopefully it makes sense.
So I'm Kim Goodspeed. I know quite a few in the room today. So I'm a child neurologist. Neurodevelopmental disabilities is my specialty, and I've been working with SLC 6A1 since about 2018 or so. And we launched our natural history study in 2021, I think. I think that looks right. Sounds right. And so my main goal is to turn your stories into endpoints. And so I'm constantly listening to family stories and thinking about how can I measure that and how can I turn it into something that's already validated, or do we need to make something new? Hopefully not. But that's generally where I'm coming from.
You already know me.
So actually, I did write down when the parents were presenting themselves and their daily issues, and it does look like, Terry Jo, you were right. The main issues that came up were communication, behavior, and motor skills. And I'm wondering, maybe to you, Andrea, and to you, Kim, who see the patients, are communication and the behaviors associated? Is it because of lack of ability to communicate, or is it lack of ability to communicate pain? Can you just comment on that before we...
I mean, I would say that what I hear a lot just in talking with families is that there's absolutely a relationship, and the more difficult communication, the more likelihood we're to have problematic behaviors. And I think that families will also find, I also kind of hear the opposite, is that once a child either kind of acquires more communication ability or gets set up to use an AAC device or something, often certain behaviors will at least be less frequent or less intense. And so I do feel like we see a relationship.
Yeah, and I think that's generally true across the board for almost any developmental disorder. Anecdotally, I had a patient, not SLC 61, he had autism, intellectual disability, got an AAC, and his meltdowns in the car stopped because he could tell his mom he didn't like her taste in music. And he told her to change the radio station. But he had been kicking the back of her seat for years in the car because he didn't like the music she played. And so sometimes it's as simple as that, which is so frustrating. But I will say, I think in SLC 6A1 in particular, that's not the full story, unfortunately. Because even when we do attain better means of communication, by whatever means that is, I think we still have some irritable behaviors that are just kind of unexplained, and they can come out of nowhere. And a medication can be working for mood stabilization for quite some time, and for no apparent reason, we've got a change. Now, there probably is a reason driving it, and we just don't know yet what that is.
Is what I don't understand is, what observations demonstrate that seizures or these delta waves are not actually causative of these behavioral issues, at least at the early developmental stage, right? We cannot exclude that. I hear that, but I don't see the proof. So I just want to make sure that if there is no proof, that we stay open-minded for this particular area of research. Sorry for being a pain.
I think that we can learn from other disorders in that regard. So, for example, Angelman syndrome, again, it doesn't necessarily, the seizures or even the delta pattern don't always completely connect with behavior. In fact, sometimes as a kid's motor skills get better and their cognition gets better, sometimes their behavior gets worse, because now they're actually not as complacent. Now they're actually more aggravated by certain things. And what I can see in SLC 6A1 is this impulsiveness and the risk-taking and the lack of perception of danger seems to be a big problem, which might not really have to do with communication.
The other piece of that coin is motivation is really tricky in SLC 6A1. So our classic behavioral strategies for applied behavioral analysis therapy, most families tell me it doesn't work in their kids. They can't motivate them with food. They can't motivate them with consequences. They can't motivate them with rewards or toys. They're they're either really impulsive and will push past that, or they'll just move on to something else without caring. So there is something a little bit different even about the behavior in this condition.
So to Jean's point, do you separate seizures from everything else, or does it come together? And maybe Zach can comment on kids in which you saw reduction in seizures. What was the change in behavior that followed? Or maybe one of the parents here can comment on that as well.
And I guess my point is, how can we exclude that we are not, that if we don't see an improvement, that it's not because we intervene too late? And again, like, I don't know. I'm asking because I don't know, and I want to understand.
Is this, you guys?
Got the contact.
So in your trial, saw the actual correlation, but it feels as if there's... Hello. Oh, great. Many families talk about their children being more engaged, more interested, and so this sort of apathy that you're describing feels very true to what we see in the study, and they're qualitatively, anecdotally, that seems to improve. The EEGs are getting better, and so I don't have a group where the EEG didn't get better, but the behavior did. So like the total correlation still needs to be worked out, but and then not in this disease, but in STXBP1, this idea of there being some developmental gains, which then leads to worse behavior. I was just telling the anecdote. There was a child who the mother was quite angry with me because before the trial, he would eat whatever she put in front of him. After Ravicti, he developed opinions and started acting like a toddler and knocking things off of the table. So I was like, hooray, he's better. She's like, you're making my life hard. So...
But thanks, Zach. This is really helpful and interesting. But Kim, to your point earlier, you said that a lot of the seizures that you see with kids with SLC are not measurable. So let's talk a little bit about that, because going back to how we would get a drug approved, and if we're counting seizures and we want to show that there is a reduction in seizures, we have to be able to count them.
So this is something we've talked about, I think, at every symposia that I've been to. And one of the tricky parts, too, I think, is what do we define as a seizure in this condition? And there's some debate over that, of what in all my training looks like a seizure at the bedside. I can press the button and it won't always have a clear correlate on the EEG, but then some of them do. And semiology-wise, the way the behavior looks, the way the stare looks, it's identical. So they're really tricky to catch. So to me, what makes sense is maybe we get away from trying to be perfect at saying we're exactly accurate, but maybe consistency is a better goal. Now, this may sound crazy, but if you'll go with me, what I'm trying to say is, let's say, parent one says, I'm counting 30 events a day. Maybe we don't care if that's seizure or not seizure, but that's their bar. And then we count the difference from that bar. And maybe we use an automatic detector on our EEGs and accept that that computer's going to be wrong sometimes, but at least it's going to hopefully be wrong consistently. And so that delta, the change, may be real, even if the absolute values are not perfect. Thoughts?
So maybe this is a good time to talk about things that people described here that really interfere with their daily lives, but are very hard to measure and very hard to incorporate as a clinical endpoint. Andrea and Kim, can you talk to that a little bit? How do you take a behavior and change it, to define it as an endpoint? How do you take screaming for 3 hours? How do you measure a change in that to define it as an endpoint? Toileting, Terry Jo, you talked about that. Let's talk a little bit about all these things that are not seizures and how they could be measured and become an endpoint.
I think we can learn a little from ABA therapists, because this is partly what they do on a daily basis. And I think Kelly was talking about it with Jackson's story that she shared earlier today about how his ABA therapists were using a clicker to track behaviors. And I've seen the reports from ABA therapists, and they're very detailed. Now, that's really hard to do on a scale, but maybe you could get away with it in the initial trial. But scaling, it's going to be really hard, and controlling and getting clean data is going to be really hard.
Yeah, so some of the things that I think about are that, take the BASC, which is a measure that looks at behavior, that I like mostly because it's the best of like what I have. But what I keep coming back to is we must have to like look at individual items, because I think a total score that I get, might stay the same, except what is going into that index might be changing. And so that's sort of the first place that I arrived to, but I don't know if that is good enough for like a regulatory body. But I mean, at least something like the Vineland and the Bailey have something called GSV scores on the individual domains, and that's a different type of metric that I'm interested in looking at, because it's a way to still define a statistically significant change in raw score. So I feel like there could be some potential there, but I feel like we have to approach this in some sort of systematic way. So like an already existing scale is kind of helpful there, because we already have a whole collection of items that we know are like validated for the construct or for the, but then how we use it, I still think we might have to be a little creative.
I have a question for you guys. Actually, I have a question for every single of you. So for you, I know you know Angelman syndrome very well, the data. So how about the Rett syndrome? So right now, what's the endpoint for the gene therapy trial for Rett syndrome? That's for you, okay? And then for Kim, so if you use memantine for SLC61 kids to stop aggression, did you see change of the at the EEG? Yeah.
I'll answer that quickly, because I don't think we have EEGs
Yeah.
post-amantadine.
Okay.
And we only have 2 kids that have taken amantadine to my knowledge so far.
Okay, and then I have a question for Jean. Yeah, so because we talk about the communication is a very important issue. So is it possible for you to dissect the circuitry affect the communication, like language area? So yeah, so I just wonder so many.
Are we answering in real time or later? Because it would be your turn first.
I don't know what the endpoint is in Rett gene therapy.
It's safety.
Safety.
Yeah, it's a phase 1/2 right now, so it's a primary endpoint of safety. I don't know what their clinical endpoints are, but I would imagine they're probably similar to what trofinetide included, because Rett syndrome has several Rett-specific validated scales that almost always get incorporated as their efficacy measures. But I know they're collecting a ton of data.
I wanted to ask something about the behavior and then go. When I was in the lab, I worked with Huntington mice, and they are aggressive mice. They bite each other so much they get bloody. Do the SLC6A1 mice, are they aggressive? Yes. Okay, that's what I thought. So that could be an interesting marker that you could look at in the mice, that you could also potentially look at in the humans, so that you could go from humans to mice instead of vice versa. So I do think, though, that one thing you can do, if you can define the domains of disease that people care about the most, then you can simply ask people, is your kid better or worse? Which is the CGI. So I'm going to have, I did that on purpose. I'm poking a skunk so she can bring up a good subject here. You can ask the families, your kid's aggression might be just pinching people. Your kid's aggression might be kicking everyone and hitting them or biting. I mean, you might have all different kinds of aggression, but you can ask if it's getting better or worse. I think Yael wants to jump in.
Well, what I was going to say is the other thing that has come up today is, lots of people have come up and said, this sounds like a lot of other neurodevelopmental disorders too. And so my other provocative concept or idea is that, do we really need an SLC6A1 CGI, or can we have an NDD CGI that captures all these domains?
Actually, I would like to have an SLC CGI, because I think there are the small differences between the disorders will make the difference in making a drug successful. And it's not going to be possible to succeed on all fronts, and you want to tailor it on a disorder by disorder basis. That's at least my perspective as a drug developer.
Could you start with a basic neurodevelopmental one and then tweak it for each disorder?
Well, there already are basic ones, right? And they're not always tweakable. That's the problem. I think, and I maybe you'd like to speak to the parents as well, and your importance in this process that we're going through is, you have a question there before I give my spiel? Okay, Dennis, go for it.
Yeah, so I think it's very related to the topic here. So the question is to you, but also for other, let's say, sciencey clinicians. So if you would be, so for those who see many people, or let's say a couple children with SSC6A1, right? And you, for those who also see other children with developmental disorders, please raise your hand if you would say, if you would see new children and someone would not tell you the genetic information. Would you, if you would be alone with that child for, let's say, for an hour in a room, could you tell if that is a child with SSC6A1 confidently or not? You don't need to be 100% right, but just to understand for us here in the room, if you see something or can note something that is rather specific, because if that would be the case, right, I would focus on that very hard in terms of assessments, because there might be something which in the realm of communication or behavior, which is rather specific and more extreme compared to other neurodevelopmental disorders, and there's an opportunity here which could be measured potentially. But it's just in general the question, do you feel in your clinical space that there is something specific and you could bet like $1 million or your right arm that you would be right most of the time if you would meet a new child and you wouldn't know the genotype?
I'm not sure if I'm willing to bet my right arm, but there's some unique features of their autism in particular, I think, and the stories really line up well once you hear the whole story of, I was worried about certain things at 4 to 6 months of age, and then 12 months to 2 years. There's a certain pattern that has emerged from these kiddos, and it's almost always they had weird staring spells as infants with unusual eye contact, missing motor skills, the hand movements too. But it's all super subtle, so like a pediatrician's never gonna do anything about that at that age. It's that you get this totality of data over time, and then they have their first drop when they start walking, and then in hindsight, maybe they had some drops when they were crawling too. And then you get a WRDA on the delta on their EEGs, and then you get their autism start to creep up, and it's much more in the rigidity, repetitive behaviors. Some of these kids are almost overly social to the point at which they can't maintain friendships because they're almost too invasive and in your face. And so they can often go not diagnosed with autism because somebody says, oh, but they have good eye contact, therefore it is not autism. So there's certain patterns to their autism even that I think have emerged. So that's a long-winded answer to say I could probably be pretty confident with that particular story that I would, and I've had some kids that I've suspected SLC6A1, and I don't think we've been able, getting genetic testing in Texas is like pulling a tooth out of my head. Like, it's hard. It's really hard. So I don't know. Did that answer your question? Kind of. Not to put...
I can answer Caddy's question from 15 minutes ago. She's still here. What was the question, Caddy?
Dissecting
Oh,
the communication
yes. So
circuits.
sorry?
Dissecting the communication circuits.
Right. So as Yulia showed, the circuits that are involved are thalamocortical, and these are the same circuits that are involved in sensation, perception, sleep, and pain. one of the most severe pain syndromes is actually thalamic lesions. So the OCDs also may involve the thalamus and the repeated behaviors. So what if some behavioral issues were due to some, painful, some perceptions of pain, right? And that are due to an abnormal activity in this particular circuit. I think we need to understand better the basic mechanisms that lead to these abnormal activities and understand if they are responsible or correlated, to behavioral changes. And I think we need machine learning for that. And you have an amazing community here. I'm impressed by how quickly the natural history study went forward compared to like what I know from other communities. And you have videos, right, of the kids, and you can use AI, to find signatures, right, that then can be used as endpoints, maybe.
So one point I'd like to, and I did start by talking to the parents earlier, ideally, in an ideal world, and so far we're not in an ideal world from the FDA's perspective or from the regulator's perspective, each child should be their own control, right? Each child should be followed for 3 months or 6 months, and then we start giving the medication and see if the medication has an effect on what we measured in the baseline. At the moment, the regulators do not accept this type of a clinical trial. They want us to enroll several children in a cohort, look at these children, decide what we're measuring ahead of time, and see if we change these. We can show any change in these measurements. So when Amber, your fearless leader, takes you to the FDA for your patient-focused meeting with the FDA, one of the things that you have to make sure that you tell the FDA is that your kids are very different from one another, and that measuring each child makes a lot of sense, of course, if the natural history study is able to support these measurements and say, it's a 4-year-old with SLC, that's what he looks like, versus a normal child, a normotypical child. A 6-year-old, that's what this 6-year-old normally does, and this is what a SLC 6A1 child can do. And then we can actually power the studies in such a way that we can get more information from them and show where exactly the drug is having effect, if it is having an effect. So this is really important. Maybe, Terry Joy, do you want to say a word or two about these patient-focused meetings, just for the parents' sake, and how they can influence the FDA?
Yeah, I don't know if SLC 6A1 has a patient-focused drug development meeting planned yet, but if you don't, put it on your radar maybe by next year to do one. These are long meetings with the FDA. They can last up to 4 hours. And it is for the FDA. You have to apply and you have to be accepted by the FDA. And it is for the FDA to really learn about your disorder. And you need the FDA to learn about your disorder from you all before any of the pharmaceutical firms really come to them with drugs. Because when the firms come to them with drugs, they will have their own ideas in mind about a clinical trial, but as long as the FDA does not understand SLC 6A1, they're just going to be using their vague rules for all neurodevelopmental disorders. So you really have to explain to them what life is like with SLC 6A1. And what I can tell from what I see is that it's really different from STX-BP1, for example. And STX-BP1, there you have the same drug working in both of these disorders, but the disorders are really different from each other. You've got to be able to show that to the FDA. So what that takes is all of you calling in, going in person, making testimonials, making videos, saying the kind of stuff you said at the podium. And also, you need a couple of healthcare providers and scientists thrown in for good measure.
How we're doing on time? How much more time do we have?
It's time for happy hour.
So maybe let me summarize, because we had some great feedback here. So clinical endpoints are not simple. We do want to tailor them for your disorder specifically so that when we have a good therapy, we can show that it's working. A lot of it will depend on creating the best measures and really tailoring every endpoint for you with your help. So I think my main message coming out of here is that you prepare really well for the FDA focus meetings and make sure that they understand what you go through and how we can change it if we have good therapies.
Thank you all so much for coming today. It was a huge success for both the parent room and the scientific room.